Okay. Hi, everyone. This is a great September 17th Physician Suicide Awareness Day. We have great speakers, Dr. Prasad and Dr. Ravi Kohli. We're going to explain us and educate us about the physician suicides and the physician burnout. And there is so much going on right now. As you all know, physician suicide is almost double than the general population. I think being lifesavers, I don't think it's the thing we should be looking at our colleagues having a physician suicide being so high. I think we need to learn more about this. I think AAPI president, our great psychiatrist, well-known psychiatrist Ravi Kohli being the AAPI president, this is a great program encouraging, educating all of us. I'm going to pass it on to Dr. Ravi Kohli, who is the psychiatrist and the AAPI president. Thank you, Ravi.
Thank you, Srini, for taking time from your busy schedule. I know you're arranging Atlanta governing bodies, so we're looking forward to being there in 2 weeks. Thank you, dear audience and my beloved AAPI members. Thank you for joining on a Sunday evening, a Saturday afternoon. Thank you. And physicians committing suicide, or not committing, dying from suicide is rather tragic. It's like farmers driving a starvation, like farmers starving or a race car driver having a car accident. It shouldn't happen, but it does happen, and it happens quite a bit. And that is a tragic situation. And there are many causes for that. And AAPI this year, under my mentorship and my stewardship, I want to focus on physician wellness as one of the primary agenda, as well as mental health stigma. Both are kind of dovetail. A lot of physicians avoid treatment because of the stigma, both internally imposed as well as externally perpetrated. So we want to address this issue on an ongoing basis over the entire year. So we have a really distinguished speaker and moderators to continue this discussion and panel. So please, shall I give the housekeeping reminders, Srini? Okay.
Yeah, sure.
Please put your questions on the Q&A tab. We have a Q&A tab as well as a chat tab. Please use the chat tab sparingly, not to kind of do any kind of interruption or distraction to the regular flow of events, because some people get distracted. But if you have anything useful to share, like a link or a message or a pointer or a reminder to the speaker, you can definitely do it on the chat box as well. So let me introduce the moderators. We have two distinguished moderators. Dr. Mukesh Lathia from Detroit area, a psychiatrist and a passionate poet who is committed to social justice, social causes like gun violence. He writes some amazingly poignant poetry and has read it and got awards for that. And he's going to be one of the moderators. And Dr. Srinivas Gokarkonda, we have two Srinivases here. One of them is a moderator and one of them are CME chair. It's a very popular name in Andhra Pradesh from Balaji Temple God. So Srinivas Gokarkonda is our president of AAPI Arkansas and a young and dynamic leader there. He's also assistant professor of psychiatry at Little Rock, University of Arkansas, Little Rock. And he's also a trained child psychiatrist, does a lot of clinical work as well. He's also a public health degree as well. So without further ado, let's get started. I guess you want, we'll introduce, you want Srini, you want to introduce Dr. Padala also right now, and then?
Yes,
yes.
Yeah. Yes. It's a great pleasure to introduce our second speaker, Dr. Prasad Padala. He is a professor of psychiatry and geriatrics at the University of Arkansas for Medical Sciences and the program director for the Baptist Health UMS Psychiatry Residency. He's the associate director for clinical innovations at the VA GREC. He's a board certified in psychiatry and geriatric psychiatry and psychosomatic medicine. He runs the multidisciplinary memory clinic at the VA and participates in geriatrics consults. And he's a national expert for the Ask the Expert in Geriatric Psychiatry program and lead the connection plans for the cognitive impairment. His research interests include management of behavioral and psychiatric symptoms in Alzheimer's disease, using both pharmacological and non-pharmacological treatments. His research is funded through NIH, Alzheimer's Association, and his recent grant focuses on treatment of apathy using repetitive transcranial magnetic stimulation and studying the impact of neurodegeneration. He also does research on the impact of loneliness on physical and mental health. He has published over 100 peer-reviewed journal articles and textbook chapters. He is an active member of AAPI Arkansas, and he's the wellness champion here. And without further ado, I will ask him to start the talk.
Yeah, actually, we had a little bit of a change of plan, right? We will, Dr. Lathia, you want to go ahead and introduce me as well? Then I'll start, and then Dr. Prasad will follow as per our agreement. Thank you.
Definitely. I'm really privileged to introduce Dr. Kohli, and so happy that a psychiatrist is at the helm of AAPI, particularly in this difficult time. So he has a very distinguished resume. He is, as I said, the president of AAPI. He's also the psychiatric medical director of SPHS, which is an outpatient mental health and drug and alcohol and treatment program, which covers 60,000 patients in 6 counties in Western Pennsylvania. He was the past clinical assistant professor at the University of Pittsburgh and West Virginia University. He's the medical director of the long-term structured residential treatment program in Bentleyville, Pennsylvania. He's the attending psychiatrist at Washington Hospital, Washington, Pennsylvania. He is board certified psychiatrist with additional qualifications in addiction, forensic, and geriatric psychiatry. He is the past president of the Association of Telugu Medical Graduates in USA, as well as the Rangaraya Medical College Alumni Association, as well as the Tri-State Association of Physicians of Indian Origin, Pittsburgh. He's also done a lot of social work, like he was the past humanitarian committee chair of SV Temple in Pittsburgh, and he is a board member of Washington County Commissioners Mental Health Advisory Board. So he is a mental health champion, and I'm really very privileged to introduce him. Please welcome Dr. Kohli.
Thank you, Dr. Lathia, for that kind introduction. Let me get started right away because we have a lot of information to share. Some of it I will be a little bit quickly pass through because I just want to be complete, so I had a lot of information added in. So again, thank you for being here. These are general statistics about all the suicides in America, including the general population. About 46,000 patients commits or die of suicide every year. And this is the latest statistics from 2020. One death happens every 11 minutes by suicide, and 12 million 12 million people think about suicide, about over 3 million plan suicide, and 1.2 million attempt suicide, I'm sorry. And coming to physician suicide, again, there is some controversy about some of these numbers, but I'll come to that later. Suicide rate has increased by 35% from 1999 to 2018. And 50% of the who have died from suicide haven't sought mental health treatment for their condition. And 50% of the UK physicians also report not seeking treatment. And 30% of the resident physicians express symptoms of depression, experience symptoms of depression. And suicide is the second most common cause of death for resident physicians. And 21% population, essential workers reported thinking of suicide in the past 30 days. These are staggering figures. And there are two numbers that are a little bit of a question marks here. The relative risk of suicide for physician versus general population was considered to be 2.27 times more for female and 1.4 times more for male. Those numbers are a little bit under kind of a review because these data were from before 1980 and before that. There is some reduction of those numbers, which is gratifying, but numbers don't tell the whole story. One suicide is too many. So again, compared to general population, suicide accounts for 26% of the deaths among the physicians of age group 25 to 35 versus 11%. And again, 45.8% of the physicians report experiencing symptoms of burnout. Whether the doctors commit twice the rate of national average is debatable, but 4,000 medical students surveyed at 7 schools found that more than half the students also experience burnout and depression symptoms. So again, some of the numbers are reiterated here. 1 physician dies by suicide every day. Again, that number is questionable or controversial. At least I would say 200 physicians commit suicide or die from suicide every year, according to some latest statistics. The number used to be 300 to 400 before, but they've been revised. So this is a very quick review of the recent report from Medscape on the tragedy of our profession. Like I mentioned earlier, physicians committing or dying from suicide is a tragic outcome to many of our valuable resource. 1 million patients lose their physician by suicide every year, if you look at it from the public health perspective. So in the report by Medscape, there are 21%, 24% of the surveyed report clinical depression and 64% reported feeling sad, which is total to 88% having some symptoms of sadness and depression. So overall depression prevalence in physicians is about 21%, which is quite high compared to general population as well. So have you ever felt suicidal? When that question was asked, 9% thought about suicide, 1% reported attempting suicide. So that's again kind of revealing how deep the problem is. These are the specialties that have reported different rates of suicidal thoughts. Again, these are self-reported from this report of Medscape survey. Interestingly, 13% of pathologists reported suicidal thoughts, and general surgeons about 12%, oncology 11%, 12%, infectious disease 11%. These numbers are different in different countries or different surveys. So just this is for the completion sake, I'm showing it. And as far as having felt suicidal, about 9% men and 11% women physicians reported having suicidal thoughts, and 1% each reported having suicide attempts. And coming to what kind of interventions or what kind of help they sought, the millennial generation are more likely to seek help or talk to a colleague and a therapist, as well as a family member, which is a positive outcome or a positive development compared to boomer generation and Generation X not having as much openness to talking about it. And why do they keep it secret? Because of these are some of the statements or reports the survey revealed. I'm afraid that if I spoke to a therapist, I would have to report receiving treatment to credentialing and licensing boards. That's a very profound and important statement. And as a matter of fact, many state boards are reconsidering their credentialing, relicensing questions in light of this development. And many organizations are working on changing the licensing questionnaire. Actually, they're not discriminating between physical health issues and mental health issues, and also making sure the symptoms are current or impairment is current that is interfering with their functioning as a physician. So they're trying to kind of narrow it down and also making it as subject to statement by the applicant, whether it is causing impairment. So that kind of gives some room for interpretation there. And physicians cannot seek help for these issues because if we do that, the temporary issues will become a career-changing record according to some people's concerns. And some people feel like they have to deal it by themselves, and they feel like They don't need to seek somebody's help. So those are some of the barriers for self-imposed barriers for seeking help or talking about help. And also we have a feeling of sense of failure if we talk about it, according to some people. So these are some internal barriers we create for ourselves. We'll come to that, why we do that later on in my discussion. And when somebody was, the survey was asking questions, how many people talk to you about having suicidal thoughts? Again, men and women report about 10%. Colleagues reported to them about having suicidal thoughts. And how did you respond? And they said they spoke to them at about 80% of them, and guided them to get professional help in 73% of the cases, etc. So I will skip the rest of it. They're not that much important here. And again, millennials think healthcare organizations should be responsible for the wellness of the physicians, and at a higher rate than other generations. And when asked what they do to keep themselves happy, spending time with family and friends was reported by 68%. And again, activities, hobbies reported by 66%, exercising by 63% as a coping mechanism. And these are the resources that are available for people to address their suicidal thoughts. And these are all available in the Medscape report. Please review it. So again, recently, President Biden has signed off on Loan-Preen Healthcare Provider Protection Act, HR 1667, that provides some resources and educational and awareness resources for organizations to utilize to address this challenging problem. About 135 million over the next 3 years are allocated for that. And history of burnout, we all know this history of burnout. Maslach index is a very famous index that we are using lately, so I don't belabor that point here. Again, most of us feel burdened by our electronic medical records, and that is attributed as one of the major stressor. And electronic burnout, electronic medical records is like a double-edged sword. It does so much good, and also it can do so much harm for us. So we take it for granted, all the good things that it does, but we are feeling overwhelmed with the demand what it puts on us in our clinical practice. So we need to find a balance, how to kind of get the best out of it. Most of the time, these electronic medical records are kind of created by non-medical professionals that kind of makes it really useless for us sometimes. So there's a loss of physicians from the system causes a lot of damage for our resource drainage for our systems. Anyway, we had a clinical burnout is a counterproductive to the goal of triple aim, which includes improving population health, enhancing patient experience, and reducing costs. But so the quadruple aim is now become more of a norm, which is improving the work-life healthcare of the healthcare providers. So this is what the quadruple aim is now, to care of the healthcare physicians' health. So without improving clinicians' well-being, we cannot accomplish those triple aim goals. So let's look at what we can do to improve potential burnout interventions. Workplace efficiencies is an institutional task that they can do to help physicians to provide better care, more efficient care, and more enjoyable care to their patients. And culture of wellness, again, this is becoming very popular and very well-regarded intervention, establishing wellness programs, identifying champions, and supporting mental health programs, as well as childcare and other resources for physicians. And then talking about personal aspect, there are institutional interventions, there are individual interventions. I want to talk a little bit more about individual interventions here today more. So personally, we can do some things that can help us. I'll go more in depth on that later on in the next few. Again, there are some personal factors, individual factors that are adaptive. That's why we became physicians. These are good qualities that help us to succeed in our chosen profession and vocation: conscientiousness, commitment to patients, cognizant of being current with the knowledge, as well as patients' trust. But these can be taken to the extreme and become a maladaptive behavior, such as not able to relax and finding work-life balance, and sense of responsibility beyond one's control, feeling inadequate, difficulty setting boundaries and limits, difficulty taking leisure time, as well as conflict, feeling selfish when we are taking care of ourselves. So those are the things that kind of stop us from being more proactive in taking care of ourselves. According to Lewis Goldberg 5-factor model, conscientiousness is what can be the good quality that why we choose this profession. But when you take it to the extreme, this can become a burden. This conscientiousness becomes a fatiguing factor. So AMA has done a lot of work on this topic as well. This is from next few slides are from AMA presentations, Preventing Physician Suicide by Elizabeth Brooks. And again, in 2016, age standardized suicide rates were 21.1 and 6.4 per 100,000 persons per men and women. Obviously, for some reasons, men have committed more suicide or attempted died from suicide. However, like I said earlier, the data collected prior to 1980 showed age standardized suicide rates were significantly higher for physicians than general population, including much higher rates for physicians, female physicians. But the latest data kind of questions that information. Now, some people believe it's still a high rate for female physician at 1.46, but a little bit lower rate of 0.67 for male physician. Physicians are not at higher risk because they're weaker or less resilient, but the opposite true. Actually, we're more resilient. That's why we have chosen this profession to be kind of care for other people. But despite of these high levels of resilience to begin with, we become kind of affected by a lot of cut by 1,000, death by 1,000 cuts kind of situation. So recurrent stress leads to physiological and physical exhaustion, and burnout is affecting half the physicians now. While burnout and suicide are very much organization level problems, not just individual ones, we need to address both the aspects of well-being. Taking proactive steps to identify and address physician distress helps ensure well-being of physicians and reduce the risk of suicide and support the patient care by protecting the workforce. So suicide behavior is a complex problem. There's no single cause for prediction of this. Suicide prediction is a very fraught field. Most of the scales are not really very good at predicting suicide. And we can predict suicide risk factors, but not really who actually dies from suicide. So, but there are some things that we can really focus on. Diagnose of major depression, bipolar disorder, alcohol use disorder, anxiety disorder, borderline personality disorder are risk factors, and prior suicide attempt. These are generally same risk factors for general population as well. Adverse childhood experiences, family history of mental health and suicidal behaviors, history of physical and sexual and psychological abuse, major life events that affect patient stability and support network, relationship problems, and domestic violence. These are the risk factors. And also there are warning signs as well. These include substance abuse, feeling and expressing there's no reason for living, and anxiety and agitation, changes in sleep patterns, feeling trapped, expressions of hopelessness, withdrawing from friends, and rage and uncontrolled anger, seeking revenge kind of behaviors, acting recklessly, mood changes, threatening to hurt oneself or others, looking for ways to kill oneself. And obviously, physicians have more fatal suicide completions because they have better understandings of toxicology and also how to kind of harm themselves. So they have more likely to die from suicide than general population for that reason alone. Then there are external factors, situational stressors, being named as a defendant in a lawsuit, general career concerns, including job security or insecurity, increasing demands, creeping demands, license restrictions, financial problems, professional isolation, recent patient poor outcomes. And what are the barriers for seeking help? See, another thing we need to be careful not to attribute everything to burnout. When people are complaining about some symptoms of exhaustion, don't brush it under the carpet of burnout or moral injury, but look for maybe some treatable clinical diagnosis like depression, bipolar disorder, anxiety disorder, even substance abuse disorder. If we intervene and treat those conditions as well, we might as well have better outcomes. So don't just look at the only, everybody has burnout these days, but so not everything can be explained by burnout alone. But there are stigma and there is privacy concerns and there is fear of losing privileges, restrictions on our career, concern from all the insurance restrictions as well, and lack of confidence in that we can further our careers if we seek help, and those things can. And also, a lot of physicians don't have primary care physicians, including myself. So we're not good at taking care of ourselves. But this is a factor affecting a lot of our self-care. We also tend to do self-treatment. That's not a good idea either. So we need to promote care-seeking behaviors. We need to, for example, generally physicians are very poor at taking care of themselves. They go for generally fewer primary care checkups, get fewer labs done. So it's important that we promote self-care, both physical as well as mental. And then we need to get some good habits like sleep and nutrition, exercise, and allowing ourselves some personal time, learning to say no, which is not easy, but we tend to want to do everything. And in this context, I want to say something. There are a lot of people who are doing second careers or a physician side gig. I wonder how much that can contribute to more burnout because they're seeking it as an intervention for burnout. But if you're doing your regular job, plus on top of that, you're doing a side job, I wonder how that's affecting your risk for burnout. So be careful. So recognize the signs and stress and depression and burnout in yourself. Reach out to colleagues for support and assistance. And I'm skipping a little bit because a lot of redundancies in my topic. And again, coming to medical students, Lottie Derby did a lot of studies on that. She used to be at Mayo Clinic. Now she's at University of Colorado as Chief Wellness Officer. She did some studies and found that matriculating medical students have better mental health profile compared to other age groups, college students. But once they enter the medical school, they have a higher rate of burnout and depression compared to their age group peers. So that's somehow our educational system or culture of medical education profession seems to be not very conducive to good mental health for very altruistic, very idealistic young men that are entering our profession. So we need to be very careful how we educate our medical students and as well as residents. So burnout among medical students predicts the developing thoughts of suicide over the course of 1 year, and also even dropping out of medical school. Additionally, burnout among medical students is associated with 20% risk of substance abuse as well. So it also associates with lower performance and other issues that can affect their career. So we need to address this and stem this problem right in the beginning of our careers. These are some of the factors that were identified. What is driving medical student mental health distress? Nature of the work, the increasing curriculum egali, lack of control, flexibility, threats to meaning, grading expectations, and research expectations. Everybody wants to publish. I'm kind of feel a little bit concerned. There's too much emphasis on publication, and a lot of them are not really useful publication. They're just pseudo-scientific publications in this drive-by-night kind of publications. So we need to be careful not to encourage over expectation of research from everybody. Competition, poorly organized clinical rotations, and what is the response? Some of these things can be positively affect our mental health. Pass-fail grading has been shown to be most effective way of addressing burnout in students. Curriculum reform also has been suggested. Research facilitators and the faculty can be really a good resource, but we need to change, also help our faculty to learn how to take care of the students' educational as well as emotional and social needs as well. So I'll skip this one here. So faculty behaviors associated with trainee burnout include lack of timely feedback, stressful relationship with the learners, education not being a priority, poor emotional support, not teaching, mistreatment, poor role modeling. So The initiatives should be including providing effective feedback, help trainees feel valued, foster reciprocal relationship, modifying problematic faculty behaviors. The faculty has to be really empowered and educated as well as trained and provide resources and time to do a good job helping the student. Otherwise, it won't work. Again, these are some of the simple things: adequate sleep, build relationships and social support. Loneliness is very deadly for everybody, including students. And we know the effects of loneliness for physical as well as mental health. So we need to avoid that. Maintain personal health, manage stress, find meaning in work, engage in hobbies, exercise, positive outlook, and avoid delaying our gratification. Is kind of, we take our kind of a pride in that, but sometimes it may not be the best thing. And rewarding ourselves for our positive accomplishment need not be a bad thing. Seeking advice about your debt reduction, maximizing work-life balance, these are very important things that we need to do. And make connections, reframe how you interpret your situation. These are some of the ways we can reinterpret. When we feel compassion fatigue, and we need to have a sense of appreciation and gratitude. When we have a sense of emotional exhaustion, having some self-compassion can help. When we have feeling of cynicism, self-awareness, and generous listening, gentle listening can help. And also depersonalization comes from isolation, can be neutralized by connecting with other people. Accept change as part of living and move towards your goals. Take decisive actions, look for opportunities for self-discovery. I talked a lot about last year about post-trauma growth during the pandemic. A lot of us have gotten better in some aspects of our personality and our lifestyle, by looking for opportunities for self-discovery. So nurture a positive view of yourself, keep perspective, maintain a hopeful outlook, take care of yourself. These are some of the suggestions for medical students' well-being. Pass-fail grade was independently associated with reducing risk of burnout, and not your hours spent on lectures and small groups, not on hours of clinical experience. So the bottom line is pass-fail grade is very positive development for stress reduction and for the students' well-being. And it did not affect the learning or the outcomes later on from the exam points of view. Student wellness trends, there is some good news. Current trends indicate that mental illness, substance abuse, burnout are more prevalent in medical students compared to general population due to excessive academic demands as well. The pass-fail grading system and longitudinal collaborative learning approaches with peer support appear to be protective for student wellness. Additionally, hobbies and all those things are helpful. Faculty development is helpful, like I mentioned. And like I said, Srijan Sen, who has the health intern health study in Michigan, had done a lot of work, and they have published a lot of data. Although depression during physician training remains high, it has kind of shown a downward trend recently. So that's good news, because there's a lot of emphasis now on physician wellness, medical student wellness. A lot of wellness programs are in place now across the country. So it is showing some positive outcomes. So there is some hope. So despite of higher prevalence, the average change in depressive symptoms decreased by 24%. So there is some improvement. There is some positive news there. And again, St. Louis, Dr. Slavin reported reducing unnecessary stressors and enhancing learning environment showed 85% reduction in the depression rate and 75% decrease in anxiety rate in medical students. That's a positive news. So we need to celebrate that. So again, these are all same things we talked about. Emotional intelligence, I'll talk a little bit about it. Mindfulness, self-compassion. So self-care, we have to start with ourselves. We tend to use self-medication and avoid treatment due to stigma, and willing to work through our sicknesses, which is not good. So what is emotional intelligence? Our ability to recognize and understand our own emotions as well as other people's, and having an awareness to manage our behaviors and relationships. That's a kind of gross description of emotional intelligence. Is it important? Yes, it is an important part of our learning. High emotional intelligence people accept themselves better compared to low emotional intelligence people. They communicate assertively and display empathy as opposed to people with low emotional intelligence. Why is it also important? For all jobs, 66% of your success depends on emotional intelligence, whereas for a leadership role, which most physicians are to some extent or other, 85% of your job success depends on emotional intelligence. And again, some healthy mindsets are gratitude, higher levels of gratitude associated with life satisfaction, including optimism, happiness, hope. So there are two frameworks that explain why gratitude can be helpful for our physical and emotional well-being. Gratitude broadens your mind in terms of interpreting negative, ambiguous situation in a more positive way, with the more positive memories for past events, with a positive physical and physiological sense of being. And I'll explain it here a little bit here in the graphic form. In a cognitive framework, we have an attentional bias that is positive, with an interpretation bias that's positive, as well as positive memory bias, leading to positive sense of psychological and physical well-being. From a interpersonal or a psychosocial perspective, you kind of receive a benefit from a benefactor. You also increase your pro-social behaviors. You develop a better network of connections, and that also gives you a sense of connection and well-being. And again, another positive mindset we can kind of inculcate or develop is optimism, sense of optimism. Optimism affects your physical and mental well-being, and it has been shown to improve your quality of life. Operationally, optimism versus pessimism can be kind of differentiated by these three characteristics. Pessimist thinks all the problems are permanent, all the problems are pervasive and personal, whereas an optimist thinks problems are changeable, problems are compartmental, as well as due to circumstances. Due to time constraints, I'll skip it here and go to next. So again, and relationships are very important for our well-being. A long-term study for almost lasting 50 years from Harvard showed that it's importance of relationship for well-being. These are very important, and studies have replicated that. Loneliness is deadly, relationships are protective, so we need to protect our relationships. And how we protect a relationship is by communication, obviously, right? Women and men communicate differently. Men don't want to have long discussions. They feel oppressed by lengthy discussions, as opposed to women who like long discussions, and also men think every question needs to be answered, but women think questions are just opening statements. And there is some difference in how we communicate. So if we understand how we communicate, maybe we can communicate better among ourselves to improve our relationship. So, and another good practice is being in touch with nature. Nature can be very helpful for our mental health and physical health as well. Spending 120 minutes outside in the nature seems to help our well-being. Studies have shown that, called forest bathing in Japanese terminology, Shinrin-yoku, has shown to help physical health by improving natural killer activity, intracellular anti-cancer proteins, reduce blood pressure, stress hormone levels, increased parasympathetic activity as well, and improving your profiles of mood state as well. So being in touch with nature is very important. And embracing self-compassion is very, very, very important for all of us, because we are very bad at that. Physicians, we always look at negativity because that's what we are trained to diagnose problems, right? So we tend to have this extra hyper vigilant sense of negative bias. So we need to overcome that by self-compassion. I'll talk a little bit more on self-compassion future in the coming slide. Exercise is very important, both from a psychological, physiological, and immunological perspective. So that's also another thing we can do. Self-compassion is so important. Kristin Neff, a very prominent researcher and writer, talks about it very much. With self-compassion, we give ourselves the same kindness and care we would give to a good friend. Instead of mercilessly judging and criticizing ourselves for various inadequacies or shortcomings, self-compassion means you are kind and understanding when confronted with personal failings. So we all fail, but we need to be compassionate to ourselves to be able to kind of bounce back from that failure or sense of failure. Research has shown it's not just a sense of like a feel-good thinking. It's a research has shown that self-compassion, self-kindness is helpful in reducing negative emotion, and also self-kindness as opposed to self-criticism is very important. And a common humanity, that we're all human, we all make mistakes, is another aspect of self-compassion. And mindfulness is another way of developing self-compassion. Self-compassion has been identified as an effective way to enhance well-being and reduce burnout for healthcare professionals. And for physicians, it should be considered as one of the essential skills for our personal and professional health. The more we practice self-compassion, the more compassion we'll have for our patients. It's like a bank account. If you don't have money in the bank, you cannot donate your money to anybody. So self-compassion you have to have compassion for yourself to be able to provide that compassion to other people. So self-kindness versus self-judgment, common humanity versus isolation, mindfulness over identification. Self-compassion is not self-pity. Self-compassion is not self-indulgence. Self-compassion is not self-esteem. Because self-esteem depends on our success, our outcomes, or our comparing ourselves with next person. Self-compassion is different. It is accepting yourself for who you are and what you are. And then we talk about a little bit of meditation. We all know, especially coming from our culture, the benefits of meditation, and it's been also accepted in this culture very much so. There's a lot of benefits from parasympathetic activation that is part of the meditative practices. It improves your depression, anxiety, sleep, immune function, cortisol levels, decision making, and coping. These are some brain changes that have been found to be present in meditators' brain, decreased amygdala and activation, and decreased gray matter in amygdala, and increased gray matter in hippocampus. And this is a default mode network. Default mode network is also kind of dampened down by meditation. Apparently, default mode network is overactive sometimes, even when we are resting and not task oriented. That kind of thinks about the past and the future, and all the emotions are generated from the default mode network. So by dampening the default mode network by meditative practices, we can improve our self-awareness and attention control. So, and another one important thing I want to talk about is smiling. Does smiling make you happy, Duquesne or not Duquesne? I thought this study must have been done by some dentist, must have funded the study. And they find that people who smile more are happier. And this study was done by University of Knoxville, or actually Wayne State University. They did a study about baseball photos that are taken in 1950s. People who are smiling in those photos, if they have a natural Duchenne type of smile, they have a 50% chance of surviving to 80 compared to people who have non-Duchenne smile, 70% chance of survival. And those who are not smiling at all have a 35% chance of survival beyond 80. So smile does make a difference. So smile can actually, important thing is even Charles Darwin, William James, the psychologists from past century have talked about the power of smile. There are some interesting studies. If you're holding a pencil between your teeth while you're watching a cartoon or a funny or comedy movie, and because that brings a natural smiling kind of expression on your face, you enjoy that more. But if you hold that pencil between your lips, that kind of makes you frown and not smile as naturally. The same enjoyment is not felt subjectively. So even smiling when you're not in a mood to smile can actually make you feel happy. So our emotional expressions actually triggers emotion rather than the other way around, according to this theory of that when we smile, actually we feel better. We don't have to feel better and then smile. So we can reverse the cycle. So again, finally, there are some tips for mental health. We talked about it in some form or other. So I think I'll end here. I think I've probably taken a lot more time than I should have. Thank you for listening patiently, and let me close my talk here. All right, thank you, and we'll go to the next speaker. Let me unshare. All right. Sorry, I don't know how much time I took, 45 minutes, honey, sorry. Go ahead, Prasad. So I think Srini has introduced him, so if you want to.
I'll get started. Thank you all for this opportunity. It's a tough act to follow after Dr. Kohli's talk. It was fantastic. I really enjoyed it. So I'm going to change the tone a little bit and make it personal. My talk is going to be dark. So I want us to take a little bit of time to reflect on the ground reality a little bit. There are 133 participants in this. So even if we go by statistics that Dr. Kohli talked about, the numbers are changing. But if you go by the statistics, 50 of us, just by chance, because there are 135 of us in this call, have depression or anxiety that needs treatment. And I can bet that most of us are not getting that. And we are, as a group, at a higher risk for suicide. So I want you to think about that one person in your life, that one person that has some of the risk factors that we are talking about, some of the symptoms that we are talking about, and contextualize this to that person when we are talking about, and think about these risk factors for that person. So before we go there, I do want to say, Dr. Kohli, when I look back at what I was 10 years ago, I'm a fundamentally different person today. I do 5 things, and I want everybody to make commitment. You might have done this already. The 5 things I do every day is I either run or walk every day. I pray. I have a WhatsApp group for Gita, right? Every day I do that and then pray. And then I spend time with my family, and I annoy my friends by calling them, even without any reason. And I meditate, and I also take time for self-compassion. So if you are not doing that, please do that, because this is high time for us to act on that. Let me share my screen. Let's go over some data. But again, Dr. Kohli has covered most of it. So let's look at this. Share. All right. Let me start my slides. Srini, can you confirm if the slides are coming through?
Yes.
All right. Very good. Okay, so we will discuss the prevalence of suicide among physicians. Dr. Kohli has already done, so I'm going to put a little bit of a layer on that, overview some risk and warning signs, particularly for physicians. And when I'm going through this, I will encourage you to, again, think about that one person in your life or your friend or family member that probably fits the picture. And we'll look at some rating scales and also look at some outlining the suicide prevention topics. So this is George Eastman. This is the guy who started Kodak Company in 1880. It's the Eastman Dry Plate and Film Company. First camera was sold in 88. And their slogan was, you press the button, we do the rest. And on March 14, 1932, he took his own life with one single gunshot at age 77. And his note said, "My work is done, why wait?" He had a pain from a spinal disorder, chronic disorder. So think again about your family, friends with pain disorders. And he had diabetes. He had loss of autonomy because of his spinal cord disorder. He couldn't actually run his company, so he had to give that up. So all of these compounded, not one risk factor, but all of these compounding. All right. So I am very comfortable talking about suicide in geriatric population because that's what I do. So 9th leading cause of death in the US in general population, much higher in older population, about 20 per 100,000 in 65-year-olds, about 23 in 75 to 84. At least in this population, geriatric population, depression is most frequent mental disorder. And physical illness compounds this quite a bit. More than 5,000 Americans over the age of 65 commit suicide. Let me lower this panel a little bit. All right, there you go. So 14 suicides per day among elderly and 1 suicide every 100 minutes. So by the time we logged in and we log off this call, one more older person. The statistics are sometimes confusing, so let's get into this a little bit granularity. You all know that there is differences in ethnicity and how suicides affect different races. White men, at least in the older phase, tend to have a lot more risk for suicide. The point that I want to make in this slide is the Asian men. This graph here in green. Again, when you look at the trajectory of this after age 60 or so, very similar to white men, although the magnitude is different. So Asian men are at a higher risk for suicide and physicians much more so. We will circle back to that. In the elderly at least, and this applies very well to physicians as well, elderly, those who attempt suicide are much more successful in completing suicide. So a quarter of elderly that attempt suicide kill themselves, whereas in younger times, you have much less efficiency of that. And physicians, as you know, because of their skill set, are much more successful in their attempts, unfortunately. And elderly also may refuse food or medicine or life's necessities. And again, think about the corollary in our population as well. Dr. Kohli talked about this a little bit. So looking at the trends of suicide rates, is a general population. Suicide rates from 1999 to 2016, except Nevada, everywhere there's been an increase in suicide rates around the country. So look at your state, look at how things have changed in the couple decades that the data is available in this slide. A general rule of thumb is probably 20 to 30% increase. But where I've become very uncomfortable so far, I was the professorial, very comfortable talking about suicide risk, but when it comes very close to home, we had an unfortunate incident about a year ago where a close friend of mine committed suicide. So this is a simulated account, so not details here. Roughly 55-year-old male physician, very successful by most metrics that you and I would apply. But when you look at the granularity later as an afterthought, we did see a lot of risk factors and maybe things were not as good as they looked on the surface. Untreated depression, anxiety, very common. Again, think about your friends and social circle, people that don't get treatment for depression and anxiety. I was in a major accident about 8 years ago, or now 9 years ago, and I had some acute stress disorder from that, and I sought help. I got therapy and really evaluated whether I needed to be on antidepressant and anxiety medicine. Very few people are open to that possibility. This one example, compounding stress at work, a lot of financial stressors that we knew after the fact, and definite poor compliance to treatment, not only for emotional, but also physical symptoms. So I get a text, I'm the first person at the scene, and this person kills himself with a single gunshot wound, which is a little uncharacteristic for an Indian American physician, but that's what we are dealing with. So this is real. But is this an isolated incident? Unfortunately, as Dr. Kohli pointed out, it's not. So let's look at different areas. So let's look at Indian perspective. Indians in average have higher suicide rates than the rest of the world. The global average is about 10.6 per 100,000. Indians 16.3 per 100,000. Could be the farmer suicide, compounding this, there are a lot of things. But one thing we know for sure, there is a huge gap for mental health treatment back home. We have over 1 million doctors in India, and suicidal ideation is reported at a varying level, anywhere from 2% to 50% in some of the medical student surveys done. And in India, the suicide rates among doctors is about 2.5 times higher. Again, there is a signal towards women physicians. There is some geographic variability. South India probably a little more than North India. And when you look at the granularity of specialties, anesthesiology, general medicine, and psychiatry jump up in Indian context, at least. Kishore et al. Published this looking at methods of the preferred methods of suicide completion, at least in India. Hanging seems to be quite high, lethal injection next, and gunshot wounds much lower in India when compared to here. So let's look at US. 400 physicians annual suicide completions. There was a survey of American College of Surgeons, about 7,900 participants in that. 6.3% reported suicidal ideation within the last year. This was about 1.5 to 3 times more than general population based on different age groups. But only a quarter of the surgeons with suicidal thoughts had sought help, and about 2/3 of them did not want to seek help. So that stigma is persistent. So much newer data, 2000 to 2014 residents, there were 324 deaths during residency, and they looked at all-cause deaths. And there was a question in the question answers. For male residents, the leading cause was suicide. And for female residents, malignancies was the #1 cause, followed by suicide. Let me put this in context. When they looked at general medical health of residents, they were better than the general population. So the mortality attributed to physical conditions was lower. So these are healthy populations, but they were having higher rates of suicide. And when you look at the residency trajectory, again, higher rates during the early part. So as a program director, I'm looking at my interns as a focus group to see if we can intervene there. The saddening part in this survey of about 1.5 decades is there was no variation from year to year. So the suicide rates were pretty persistent. Let's jump the pond and go to England and Wales. This was a retrospective study of NHS doctors between 79 and 95. So a little dated data here. There were 223 suicides, and males was 19.2 per 100,000, and females was 18.8. But this is the point that Dr. Kohli was getting at. Females had a higher mortality rate compared to general population. So again, putting that that graph that I showed in the beginning, males have much more higher suicide rates than females in general population. So although the physician male suicide rates are high compared to general population, they are lower, and females, that's why they show up. It's about twice the risk, at least in older data set, again, 1979 to 95 data set. There was no difference with seniority and time period. They measured 1979 to 95 in 4-year blocks, and they didn't see any difference. Again, similar distribution, general practitioners, anesthetists, psychiatrists in that group. Let's now go to global perspective. Let's try to wrap this up. And again, Dr. Kohli did have a slide saying that about 1.2 million people attempt suicide. In 2016, there were 800,000 suicide deaths. So suicides actually kill more people every year compared to natural disasters, wars, violence by others, and conflict, all combined. Suicide on one side, all of them on one side, and suicide still is a higher burden. And physicians have higher suicide rates than general population. We talked about that. And there was a meta-analysis done of quite a few articles, 7,000 plus articles. Finally, they found 13 good articles. And in this female physicians, the SMR was 1.46. So earlier cohort, we had seen it twice the risk, here 1.5 risk. And there are some decreasing rates since 1980, as Dr. Kohli pointed out. So depression, substance use, or both seem to be one of the risk factors that are common thread in all these studies. Gender, we have seen the female gender a little bit, increasing age, interpersonal relationship issues. One of my interns just got separated from his fiance. So again, I'm thinking about contextualizing this and saying, this is one person I need to keep a closer eye on and see what's going on, look for signs and symptoms sort of thing. Okay, so synopsis, one doctor dies by suicide each day in the US, or roughly so. So in the time that Dr. Kohli asked me to give this talk, roughly 10 doctors have committed suicide. So that's unacceptable. We got to do something about this. So we are higher than general population, maybe not twice, 1.44 times. That's the consensus at this time. And female physicians are at particular high risk. All right. But do the numbers matter? Dr. Kohli said, one physician suicide is one too many, right? It's we are coming up on the anniversary of my friend's death, and we are still recovering. It's not just the family, close friends. We are confused. I feel inadequate. I was very close. I spent about 90 minutes the day prior with him, and I feel like I'm not a good enough psychiatrist because I did not pick on those symptoms. There's guilt, there's anger towards me, anger towards him, particularly angry at him, his patients. It's a very small community, Little Rock, so we are all impacted by this, and a research enterprise is reading. So every physician suicide impacts so many people, and we got to do something about it. We said, we are slightly higher rates than veterans. And I work in the VA, and VA, there's a robust suicide prevention network. Every VA hospital has a suicide prevention coordinator, 3 or 4 people working round the clock trying to help veterans. And here we are at a higher risk, and we do not have any mechanisms in place. We'll talk about that. So what is really unique about physicians, right? Let's talk a little bit about protective factors. We've been talking a lot about the risk factors. We have better health insurance. We are financially more secure. We have more access to mental health. If we actually want help, we actually have more health available. And we also know that the benefits of mental health are important, not just for mental health. We know that if you have a heart attack and you have depression, you don't treat depression, your cardiac outcomes are worse off without treating depression. But does that translate to actually going and getting treatment for depression after a heart attack? The data doesn't show that. And I know personally that people are not doing that. Let's look at the risk factors. I'm going to look at the risk factors as individual, clinical, societal, structural, and some endemic factors related to physicians. Let's look at this. And again, as a psychiatrist, I look at the 5 axes. Let's look at axis 1, axis 2, axis 3 for the medical illness. Axis 2 is personality disorders. Axis 1 is psychiatric conditions. Axis 4 are life stressors, and axis 5 are functioning. So let's look at this in general and then contextualize to that physician friend of yours, right? For those with mental illness diagnosis in the last year, rates of suicide are 70 out of 100,000. In the general consensus was about 20 out of 100,000 in the general population. So having mental illness alone increases your odds by 3 times, right? So depression, substance use disorder. So think about this. Is your friend, one of your friends, is he drinking more? Is there a substance use disorder that's going undiagnosed? In friends of older age, are they having memory problems? Are they having early memory problems are more problematic because they have insight into the deficits. They are not functioning this as this super doc that they are used to all their life, and their faculty is declining. That's a higher risk. Do you have a friend like that you need to pay special attention to? Hopelessness is a known risk factor for recurrent suicide attempts. Mass depression. We are so good at masking depression and not talking about that. And even when people talk about that, we don't treat that well. And even physicians that start an antidepressant may not give the antidepressants the entire course that it needs. SSRIs like Prozac, 12 weeks of minimum treatment to get their treatment benefits, and you got to potentially continue that for a year or two. So Our physicians are also very keen on that small print side effects, and I've seen my colleagues having more of those side effects than my patients. With depression, when there is comorbid anxiety and substance use, it's a disaster. So got to look for that. So how prevalent is mental illness among physicians? So I found this global study, 17,500 residents across 18 countries. And pretty consistently about 25 to 30% clinical depression. Contextualize this. If you are working with a program, I am a small program, I have 10 residents at this time, 25 to 30%, that's like 3 to 4 people in my residency program that have clinical depression, or at least I should be by the numbers. Probably I got lucky that I don't have anybody, maybe not, but I got to look for that. Right? In a UK-based large multi-center study, they looked at consultants from 5 specialties, 94 to 2002, and they found a 5% increase in psychiatric morbidity, a 9% increase in burnout. All right. And in the US, the general consensus is that every year there is a 0.5%, 0.5% increase in psychiatric morbidity. So we are looking at populations, maybe they are more aware of the issues, more willing to talk about that. We are loosening our diagnostic criteria to some extent, but there is increase in psychiatric diagnosis. There was another national cross-sectional survey, hospital consultants. This was in 2004, than the previous one, and there was 32% incidence of depression. So general theme is there's a lot of depression. We got to look for that. All right. And the last bullet point on this is still worrying. Only about 13 to 36% of physicians with mental disorders seek help. All right, now let's look at access to, Dr. Kohli talked about this with conscientiousness, right? So high neuroticism, tendency to focus on the negative affect, that's an issue. So are your friends smiling? Are they clutching that pencil with their lips or their teeth? So you got to look at that. This is what you do as a friend. You look at your friends and say, hey, why are you not focusing on the positive things that are happening, right? You are still in the top 1% of financially sound Americans. So why focus on this one small niggle in your professional career, right? Low openness to experience, obsessional, anxious traits, prioritizing care for others than self-care. So talking to your friends and saying, hey, what are we doing about, right? I had a friend who had a heart attack in his 40s, 43-year-old having a heart attack, Desi guy. So I started a Bhag Desi Bhag campaign. So we started a running group where we had 7 new people complete a half marathon in Little Rock through Bhag Desi Bhag. So creating something where people have safe space to talk about and do physical activity together. All right, physical illness. So look at any CNS disorders, high risk for suicide. Again, in Eastman, we saw chronic pain with a spinal condition. So think about these, and these things compound. This is an interesting statistic that I like. So if somebody had no chronic illness and somebody had 3 illnesses, their risk of suicide is 3 times higher. Now, if you compound this to 5 chronic illnesses, and the risk is 6 times. So these things add up. So look at that. So let me combine the axis 4 and 5, loss of autonomy. Again, loss of autonomy in physicians can present in different ways. A private practitioner bought into a bigger infrastructure because of changes in rules, and now he has to play by the rules, right? That's the flavor of loss of autonomy that we need to be talking about. When we look at functional decline, ADLs and IADLs, it's so easy with patients, if they stop driving, and that's it, that's the impairment. But for physicians, the impairment may be very different. Let's talk about that. It could be a disappearing act. It could be clinic rage. It could be presenteeism, right? Disappearing act is where they are not answering their phone calls as much, not returning their patient phone calls. They are absent unexplainedly, or they're late. They're typically not late, but now they are late and frequently calling in sick. So this is occupational dysfunction. We're not talking about overt dysfunction. The distinction is not whether they're working and they're retired. The distinction is whether they are going to work at the same time, but not as productive. That's what we need to be tuned into. Are they getting more temper lately? Are they being snappy with friends and family? And if so, what are we talking about? And Dr. Kohli outlined so many good things that we can do for burnout. So look at those things. All right, we talked about, Dr. Kohli covered this quite well. Clinical and professional risk factors, electronic health records, things that are supposed to help us. 60% of the physicians surveyed talk about stress from the electronic health records. Dr. Kohli pointed out that most of these are developed by non-physicians, and that's a stress factor. I see this, I work at the VA, I use CPRS, which was developed by physicians, very different than when I come to my university affiliate and use EPIC. So I see the difference. Maybe we need to be the drivers to change things. What else? Licensing and credentialing requirements. There was a study looking at, there was at least a 20% underreporting of depression and the treatment because of the requirements to talk about that or report that. So there are things changing. Maybe AAPI can be the change factor here, influencing your local medical boards to change their questions. Maybe those things are already working there. All right. We won't talk about burnout. That's well covered. Okay, so warning signs of imminent suicide risk. So we talked about general risks. So if your friend who is doing well suddenly gets very angry and talks about revenge-taking behavior, clues to think about that. Reckless behavior. Obvious clue is they are giving away their personal things, right? Sentimental personal items to things, or dropping things in conversation after a shot of vodka, saying, my problems are going to go away next week, right? So you got to be aware of this and got to think of your friend as this vulnerable person that might be going through depression, anxiety, societal stress that he's not talking about, and he's dropping these clues, right? If there is dramatic mood changes, if they are not sleeping well, if they say that they're feeling trapped, right? All these things to look for. Looking for ways to kill self, right? Do they have a gun? Do they recently buy a gun? Do you have enough rapport with your friend that if they bought the gun a week before, will they tell you? If not, we may have to work on that relationship to create that safe environment. There are protective factors. Again, I want to go back to a little bit of this cultural or religious beliefs. So my Gita, that really helps me be grounded, think about myself as much smaller than the bigger purpose is. So those things are important. Inculcating that is important. Sometimes fear of harm is important. Fear of letting the family members down is very important. So talking about these protective factors, or maybe bolstering these protective factors. I see in the introduction that Dr. Kohli was on the SV Temple in Pittsburgh, right? Building those relationships. So that's very important. What are special considerations for physicians? It's all about confidentiality, right? If we are making mental health referral, make it away from their hospital, somewhere else. Telehealth, again, Dr. Kohli, this is where AAPI can be very, very instrumental. Srini Gokarkonda and me have been in situations in Little Rock where we have community members seeking help and we don't have any help available because everybody knows everybody. So maybe we need to have a call center for physicians of Indian origin or even Indian origin people. So we don't have those resources at this time. I am very proud of this year's theme of healthy physicians and looking at all these stress management ways. But when you're attending these conferences, I really want you to think about, what can I do today? What is that small step I'm willing to commit today? There is a lot of information. You know this. The MRI scans show that meditation helps. But if meditation is not in your wheelhouse, then you got to look at simple things that work for you and say, how am I better today in a wellness way than from yesterday? Asking about suicide does not increase the risk of suicide. So please be bold. Talk to your friends about suicide. Ask them. So these are some other questions that I think they are already covered. Let's go here. Ask your friend. This is for not friends. These are just acquaintances, right? Ask them, how are they doing? And not just as a polite inquiry, but really ask them what they're doing, right? Would you mind talking about how you feel? If you suspect that they are not their self, tell them that you are smiling less lately. What's going on? Is your marriage okay? Talk about that. Can I help you? Right? For your friends, ask about intent. Talk about that. Are you thinking about hurting yourself? Are you thinking about ending your life? Have you thought of how to do it? Ask about that. Ask about suicidal plans if they have any. Ask if they need help. Again, this again goes back to building that relationship for years before you get to that point where you can ask this question. But suicide is seldom a one-person act. They have told somebody in their life about their suicidal ideation. And are we receptive enough to pick on that clue after 2 shots of vodka when you're talking with them, right? That's something that you got to really be mindful of that. There are ways to screen this. Again, nothing good about suicide screen, but talking about depression screens. I really like the PHQ-9. I like the sad person's mnemonic that we all talk to our trainees. So look at gender. For physician suicide, it's not male sex, it's female sex. So got to look at that, right? Although male sex is also very high risk. Age, both young and elderly. Depression. There's a lot of depression that goes underdiagnosed. Previous attempts, and would you know if they have previous attempts? Alcohol, right? 15% of physicians surveyed in the US reported problematic alcohol use. So got to look at that. Impaired reality testing. If I go away today, everything will be better. My family will be taken care of. You got to challenge those thoughts and say, maybe that's not reality, right? Lack of social support. No spouse. No spouse can be tricky. It's not a black and white. It could be spouse that has a chronic illness now, so they are not as emotionally available, or they just moved to a nursing home. That's not losing a spouse, but not having a spouse either. So those granularities. All right, PHQ-9. Okay, I'll let you look at this for a second. Geriatric depression scale. I really like this because it's a yes, no answers. It covers only last week of symptoms. There are different varieties. I like the 4-item version for quick reference in primary care settings. All right, so what are the risk factors than the traditional risk factors? So has your friend had a bad patient outcome, right? Has he been named in a lawsuit, right? So if he or she has been named in a lawsuit, then you got to pull resources together. You got to have a party and sit down and talk about that, provide them support, right? Has there been a restriction on their work or license? Has they been impaired? Right? All these things. All right. So what are some of the interventions? We don't have much, so it'll be a quick shot at this. you're already doing the wellness workshops. I really like that. And again, as a person, think about what you can do for yourself doing that. Starting early in training is very, very important. Our medical students are getting great wellness exposure. Actually, one of our own, Dr. Puru Thapa, does a great job with wellness. And I am so jealous at times of the medical students that are coming to work with us, that they have such good resources in place. So that's good. We need to do this from the very beginning. If electronic medical records is a big stress, then you got to look at using macros, using templates, bringing a dragon, right? I use dictation all the time to do my notes, getting scribes, getting around it. Policies, we talked about that. Dr. Kohli, again, a charter for your team to think about. Health Education England started this well-being guardians. So they've appointed one well-being guardian for each hospital. So healthcare workers can go there and talk to this guardian about their wellness. So thinking about this, investing into this is very important. So this is a framework I found in Lancet 2021, Harvey's article. Again, looking at a broad stroke of what all we be doing. So we talked about promoting wellness in medical schools, really normalizing help seeking. I think in AAPI that we need to do. We need to normalize help seeking within our physicians. And not only the new entrants into the country, but also people who are well established, where there is a little bit of a burden that you're already settled, you can't be having problems, you have to take care of the rest of the folks, sort of thing, right? Reducing administrative burden and giving more autonomy to physicians. Again, this is something hospital level. Improving leave arrangements, right? I have an example where my brother is a fledgling private practitioner in Florida. He's a private practitioner, primary care. I work at a VA, right? I take regular vacations. I go on cruises and other stuff. I force my brother to go with me. And for him, everything is based on productivity. So he's thinking about coverage. He's thinking about the generativity loss and other stuff. But I have become this annoying brother to take care of my younger one and say, hey, we got to take this, and you lose money, that's fine. Yeah, you'll make up later, sort of thing. So be that annoying friend to your friend who is so driven that they're not taking a vacation, right? I'll send this out so you can look at all of these things. But again, it's not one person's, it's entire culture that needs to change. And let's see. Okay. Individual interventions, right? Assessment and treatment of mental illness, we're not doing a good job, so we got to do more of this. And for the newer generation, maybe using mobile apps, a lot more work being done on that, using telehealth so that I can actually get help from somebody in Georgia rather than in Little Rock. There are some models looking at primary care-based collaborative depression management, where there is an antidepressant given and there is a care manager. We're actually exploring a telehealth care manager for our practice called Mandola, and I think we may invest in that. In intractable depression, you know you can treat this. You know this lithium works. Although we did a big study at the Veterans Affairs where we didn't find lithium to be any extra benefit over what the VA already does. All right. Okay. So some resources, last week, Dr. Kohli covered this. So National Crisis Line 988, there is a specific line for physician support line. And there's also a website and an email that you can talk to peer RX Med, where you can actually get a peer to be your support. And I will end this with a challenge to Dr. Kohli, Gokar Konda, and all these folks. Maybe it's time for AAPI to have their own, to support our own people. Thank you.
Thank you, Dr. Prasad, and thank you, Dr. Kohli, for your excellent presentation. Great talk. A lot of epidemiological data and research data, evidence-based research data. and the causes for suicide and the protective factors and the risk factors. And Dr. Prasad touched upon importance of wellness, staying healthy. I think he mentioned 5 things and he did not mention the 6th thing, which is food for him. And he did not mention that. So
I eat too much of it.
yeah, he forgot to mention that. So I just want to remind that. I know this is a great need for resources for the Indian American community. I'm constantly talking with Dr. Kohli and Dr. Prasad in establishing that physician call center for Indian American community. It can become a reality, but there are some kinks to work on, and we will start working on that. So without any delay, we want to go into the chat and see the question and answers from the question and answers section here. Let me pull the questions here from Ved Gosain. Are the suicides of psychiatrists same as other physician groups? I think, Prasad, you can answer this question since you mentioned.
Yes. Thank you for the question. Actually, there is some conflicting data about which specialty is at the highest risk. In some studies, consistently anesthesiology comes up, but psychiatry is up there, not the topmost, but it is up there as a specialty that is at a higher risk for suicide. It's a tragedy that psychiatrists are on that list to start with, because we should be more aware, right? We shouldn't be in that list, but we are.
So next question by Dr. Chintapalli. She asked about the etiology of suicides. I think both Dr. Prasad and Dr. Ravi has talked about the risk factors for suicide, including the depression, anxiety, stress at work, a lot of other factors, including medical issues like diabetes, COPD, central nervous system disorders, things like that, all can contribute to the etiopathology of suicide. And then Scott Cook has asked a question about, has COVID and pandemic associated isolation increased the burnout and suicide in physicians? I think Ravi, you can answer that.
Yeah, Dr. Cook, thanks for joining. He's my colleague from Pittsburgh area. There is some evidence that the increasing isolation and restrictions has caused some difficulties for our population as well as physicians because of our income, effect on the income as well as our ability to practice, and also facing risks every day. And being a physician and risking our lives has all added to the burden. And some of them have actually retired and quitting quietly, and are quitting completely is happening. So it does affect. I don't have the exact data, but there is some anecdotal and some real data to show that.
Atul Shah, Dr. Shah has asked about changes in healthcare provision with hospitals controlled procedures and additions of extended PA and APRNs helped or hindered the provisions or negative provisions. So basically, I think the question is about, has the APRNs and PAs helped reduce the stress or increase the stress on the physicians?
Let me take a stab at that. I mean, it's a double-edged sword. Some physicians like having that, and some people resent it, especially younger generation. Actually, I mean, they don't even like the word APR. So I think there's a mission creep, and we need to be the real leaders of this care. And some of us are actually benefiting from it. Some of us are abusing it. So we need to set some higher standards for these kind of changes. So can Dr. Mukesh ji ask next question? So we have.
Yes.
Thank you, sir. Yeah.
Yeah. Thank you for both of you for such an illuminating talk. One of the questions that Dr. Alka Patel has asked is, don't you all think that our Indian culture also plays a role in making us feel that we are successful if we show off our wealth and that we are flawless? So anyone
Yeah.
can answer that question.
Yeah, I mean, somebody said, I don't know who exactly said, I think maybe Mark Twain, the worst thing we can do to our happiness is comparing ourselves with our neighbors or keeping up with the Jones. That is the prescription for misery. And that is how, if we tend to live, then we are causing a lot of damage to ourselves. I think self-acceptance, self-compassion are more important than comparing ourselves with our neighbors. So those are positive psychological mindset that we all need to inculcate. As for the Indian culture, I think Dr. Prasad mentioned that spirituality and religiosity can help. And we tend to have a little bit more religious or spiritual mindset. It does help to some extent to feel connected to purpose and cause bigger than us. And that brings us humility and a sense of kind of connected to each other. So those are good parts of being religious or spiritual. I consider spirituality is higher level of evolution of our psychology than religiosity. Religiosity sometimes can be divisive or restrictive or limiting, whereas spirituality can be more liberating and more encompassing the humanity as well as the universe. So spirituality is what I prefer and I promote among my patients and my friends. Dr. Prasad.
Yeah, I just want to add a little bit to that. Thank you for the wonderful answer. Maybe social media is also making things worse a little bit in this, where we post a lot of wealth on social media. And I think as a community, we can influence that, right? We can, because social media thrives on the feedback. So if we as a community make lesser, give lesser feedback to wealth and opulence, right? I want to see a community standard when we don't praise a young woman for her physical beauty. We actually talk more about her strength as a person. And again, I'm not talking about superficial things like GPA or scores or big cars or something. So I think as a consumer of social media, we can also influence what we like and what we don't like. And maybe in a decade or so, things will change because as a community, we are liking more substance over style.
Yeah, let me pitch in something here. I think our system, our economy promotes conspicuous consumption, right? We want the latest shiny object. We want to replace our new phone with a new 14 iPhone. So that is part of our multi-billion-dollar media marketing industry. So we need to kind of not fall for it. How can we prevent that? Gratitude, appreciation of what we have, not what we want to aspire for more and more, because there's an endless chase of misery and unhappiness, chasing and chasing and chasing. But having contentment, having gratitude does promote resilience and sense of a kind of purpose. You're not distracted by shiny objects, more purpose and meaning in life. So that's my take. Thank you. Excellent question, Alkaji.
There's one question that Dr. Jagirdar is asking is, are doctors who own guns at home more likely to commit suicide? I'm from Michigan, so I have my own take on it, but I don't want the speakers to talk about that.
Prasad, you go ahead first and then I'll think about it, yeah.
Maybe Mukesh, you need to start with answering that question because he has some background on that.
Yeah, yeah, I think most physicians actually do commit suicide by more toxicological agents because of the availability of drugs as well. Anesthesia is especially at risk for that reason alone. And guns are prevalent everywhere, but probably gun ownership is probably a little bit less in physician community compared to other non-physician communities. So, but once you pull the trigger, the outcomes are pretty lethal and fatal. So the room for margin is very less there. And as opposed to gun violence in gun deaths in India, in America, the pesticide poisoning is the biggest cause of death in India. And there are a lot of restrictions on pesticide purchase now, but same restrictions are not in place in this country for guns for obvious reasons. So we don't want to go there, but we need to talk about it in a public health perspective rather than a political perspective on that.
I think impulsivity drives suicides, right? With gun violence, and also having a gun will increase the death by suicide by 30% versus other lethal means.
Yeah.
So having a gun itself is a big risk factor.
Yeah, especially as a physician, as a psychiatrist, one of the things we do in screening for suicide risk, we want to make sure the guns are removed or secured or kind of got rid from that vicinity. So that is part of our job description to ask for guns and the risk for gun violence. So we do that. But we do face a lot of criticism from some quarters for that we're taking away their constitutional rights. So, but we always have to weigh the pros and cons and of everything we do. And I think saving lives sometimes to the point of annoying our patients is more important. Thank you. So Dr. Chintapalli asked some questions, a little bit hard to answer.
She asked about the etiopathology and also asked about research and how many of these doctors meet the definition of ASD, the new diagnostic criteria from 2018. Are you talking about the autism spectrum?
Right. She's Dr. Chintapalli is very passionate about autism spectrum, but I'm not sure there's any higher risk of suicide in autism spectrum that we know of, especially in general population, but I don't know with Dr. Padala or even child psychiatrist, Dr. Gokarkonda might be able to shed some light on it.
I think, again, suicide is, again, a higher intellectual capacity, right? And if somebody contemplating death, but, if there is a suicide or self-harm in autism spectrum, it could be just by impulsivity or by accident. I don't think it's a deliberate suicide attempt by a person with autism. Right. I've never seen one so far in my practice. So.
Right. So let me crawl through. Thank you for a lot of positive feedback. How long can you continue on SSRI? Dr. Govila asked. Do you want to answer, Dr. Prasad?
Yes. So I'm a geriatric psychiatrist, so the minimum amount of time before I even think about changing a medication is SSRI is 12 weeks. So minimum of 6 to 12 weeks before I say whether they're effective or not. And my rule of thumb is if they had one prior episode of major depressive disorder, the chance of recurrence if we discontinue SSRI within 1 year is 80%. So if they had one major depressive disorder episode before, then I continue for 2 years. And if they had more than one, then I'm talking about 2 to 5 years. And if they had 3 or more, then I'm talking about indefinite treatment for SSRIs.
Let me ask you this question from the list here. Dr. Shah, again, a good question. Let me read it verbatim. It's not quite simple to start observation and analyzing friends or relatives just like that. There has to be a trigger by the person in question, but I can't say one could find it in a routine task to make simple observation, but you could give us some pointers, Doc. So how can we kind of find some subtle clues, or Prasad, since you can answer that question, I can also maybe pitch in too.
Yeah, again, I'm no expert in this. I failed. So hindsight is easier. I can look back at many of the interactions that I had with my friend, and with this awareness, I'm always trying to connect dots. But prospectively, without knowing a trigger, you'll be spoiling a party if you start analyzing every friend with these thing. But the point I'm trying to make is sometimes we think of ourselves as superhuman. We think of our friends as superhuman. And the thought of our friends suffering from depression or anxiety is a very remote thought, if that is one in any person. So people don't think about this at all. So I want us to start thinking about it. I don't want you to analyze your friends at a party. But if there is an event, then we got to be thinking about this. Again, going back to my friend, there was a strong family history that I wasn't aware of a suicide using the same method by a close relative. So just being aware of that. I totally
Okay.
agree. It's impossible to do this prospectively. Yeah.
Yeah, scrolling from down from the bottom here, Dr. Gupta, Sharad Gupta asked about Ivy League expectations, putting pressure on the family by kids, by the family on the kids. I mean, again, we need to, like Dr. Prasad said, we need to change the culture of our ever-ending creeping aspiration that kind of sometimes become a albatross around our neck. So we need to change our culture of happy acceptance and being kids be who they are rather than molding them into our own clones. That's not what we should be doing as parents.
In the
And
wellness, Ravi, in the wellness perspective, since you mentioned that, in the wellness perspective, there is a question about, are we human doings or are we human beings, right? So we start with the medical school and then we come here, we do residency, fellowship, and then practice, and there is no end to that. So we keep doing things instead of being a human being, right? So I think we need to focus on ourselves,
yeah,
at least, when we
yeah.
are successful in our areas.
Great point. I want to add 3 points to that. That's a great discussion. We all have kids and think about this all the time. So the 3 things I do is, first of all, I impress upon my kid that I am not superhuman, right? I am a psychiatrist in the middle of nowhere, right? In Arkansas. So I tell them this. I show them my mark cards and say, I was never a superhuman and I am doing well. I am top 1% today, right? In America. So if I can do it, you can do it. So I tell them that. And it's not about whether you put emphasis on Ivy League or not. It's about whether your kid thinks you put emphasis on Ivy League or not. It's a complicated thing. You got to talk about that. You got to tell them routinely that that's not important. My daughter was at one time very, very driven, really wanting to do whatever she wanted to get into Ivy League, right? That was her pressure. But for people, outsiders, it always seems like the Indian parents are driving it. So she wanted a cat. And we said, hey, why don't you focus on your ACT? You do well, we'll get you a cat, right? So she took ACT, and just to make it a point, after she was done with ACT, we picked her from there, went to the animal shelter and got her a cat and told her the result was not important to us. What you did was important to us, but not what the outcome is. I think saying this very specifically and repeatedly, because your kids are judging you all the time, and they are judging you based on the stereotypes of Indian American parents, although you may not be doing that.
A good answer. Dr. Dondeti asked similar question. From an Indian perspective, culturally, how do we address, I have experience with physician patients of Indian American patients who feel there's a gap in the cultural understanding of depression, social factors. So I'm not sure. But again, like you said, our culture has both pros and cons. Our culture also has given us Gita, which always tells you don't judge yourself by your results, not the outcomes, but the effort. karmanye vadikaraste ma paleshu kadachana, right? So don't judge yourself from a, see, there are so many good things in our culture which we have kind of gotten away from. I think if we get back to some of those roots, and instead of the materialistic, consumeristic culture that we kind of borrowed from Western to make it hypertrophied in our psyche, we need to get back to a little bit of our original cultures, or indigenous culture of acceptance, compassion, community, and something bigger than us. So those things have to be also be, again, cultural sensitivity in therapy is very important. And so from an Indian perspective, when Indian patients come, I think if they're Hindu scriptures do have some good ideas that we can kind of use to kind of make some headway with them.
So I think one last question from Dr. Sudhakar. He joined from India, so I just want to give him a chance to answer his question. What is the chance of person committing a suicide or attempting a suicide after surviving an attempt? If Prasad or Ravi can answer that.
Yeah, I mean, the suicide attempt is again increase your risk of suicide in the future, and also being a child of a suicide completer also makes you 4 times high risk of being suicidal as well. So it does increase the risk. So it's not like just an attention-seeking behavior that we need to just not wish it away. So again, I think it's a long and healthy discussion, but I think we actually appreciate all of your participation and involvement in asking so many really good questions. Dr. Latia, you want to say your poem in a couple of minutes or so?
Okay. Well, yeah, I'm a poet, and this is the poem I'd written a few years ago. We talk about feeling guilty as a clinician. One of my patients committed suicide. So basically, this poem is dark, and it shows the clinician's guilt, so to say, and an attempt to redemption, if you will. So I'll just recite it quickly, about 3 minutes. The title of the poem is Confession. He came to my door to shop for a handful of glee, not an ocean, but a drop. He came to my door to shop for a handful of glee, not an ocean, but a drop.
Dr. Latia, when you're not looking at the screen, the voice is trailing off.
Okay. She came to my door to shop for a handful of glee, not an ocean, but a drop. What an irrefutable act of havoc she wrought, trying to steal a ray of golden sunshine and getting caught. What an irrefutable act of havoc she wrought, trying to steal a ray of golden sunshine and getting caught. In this lay of the land, I'm still very well sought. On my grandiose part, I worked hard, or so I thought. I gave her pills and let her see a therapist like the rest of the herd. She looked up to me like a naive, trusting sheep, to Jesus, the shepherd. She thought I was a messiah, a psychic, or one who read tarot. She thought I was a messiah, a psychic, or one who read tarot, while I dangled hope like a bright orange carrot, well outside the reach of a caged, hungry parrot. She was futuristic, as they say, and said goal. She was futuristic, as they say, and said goal. How does one penetrate the dark abyss of soul? One fine day with no foreboding clue or gist. One fine day with no foreboding clue or gist. Many a pill she took and cut her wrist. We had no time or intent to delve in her waters trouble deep. Briefly, we brooded over her and quickly moved onto the next sheep, listlessly lying like an unfinished auto carcass in a GM assembly line. With clever pretense, our conscience was intact, fine. Just like that, she was wiped from the earth's face. Just like that, she was wiped from the earth's face. A bitter truth I'm pressed to embrace. I'm condemned to see her sometime, someplace, in the timeless presence of his eternal grace. She will still be herself, timid, shy. I will be forced to sit through her sad, forlorn eye. We will then have no dealings of cash or kind. We will then have no dealings of cash or kind. In a flash of moment, my eyes would go blind. And in front of them, my work, my passion, my lies would rewind with a soft hushed tone in a feeble attempt to atone. With a soft hushed tone in a feeble attempt to atone, I will confess to him and her too that claim as I may, I never knew the inglorious uncertainties of human mind. In a feeble attempt to atone, I will confess to him and her too that claim as I may, I never knew the inglorious uncertainties of human mind. Once more, my cunning from the world I will save. As a heavy burden of recurrent guilt, I will carry to the grave that she came to my door to shop, just for a handful of glee, not an ocean, but a drop. She came to my door to shop, just for a handful of glee, not an ocean, but a drop. Thank you.
Let's conclude. Srini will give us some concluding remarks and we'll make some announcements as well. Thank you, Srini. Gangasani.
So there are two, Ravi, there are two attendees that were raised hand. Do you want to just ask those people? I think they've been raising hand for quite some time. Bhushan Pandya, I think Dr. Bhushan Pandya and Dr. Raj Dundeti. Are you guys?
They might have left. But anyway, let's see. Are they still here?
I think they're there in the chat. They're mute.
Okay. Yeah, go ahead and yeah, Bhushan. Okay, Bhushan, can you quickly make a point and then we move on because we're really way into next half an hour. Dr. Padala has to leave, and
the first point is that this was one of the best presentations, and the second point is that for physicians, maintaining their license is very important. So seeking help, it is important that we have legislative support of not losing a license from the Board of Medicine. And there are states which have laws in place to help that. That was the only comment.
Thank you, Bhushan. Dr. Kundeti, are you there? Yeah. Okay, so Srini, go ahead. Gangasani, Dr. Gangasani, please go ahead. Yeah.
It was a great job. I think Dr. Padala and Dr. Kohli, it was a great talk. It was actually eye-opening for so much new information. As a cardiologist, I didn't know so much about the burnout and so many issues you raised. I think it's a great talk. I think Dr. Mukesh and Dr. Srinivasa Gorkarkonda done an excellent job being the moderators. I just want to do two reminders. One is the next CME talk is on October 1st. It's about the thing which goes to my heart, South Asians and the heart disease. We have a really great speakers from Johns Hopkins and from Boston, I think Harvard. I think educate us about how South Asians have so much more heart disease and what we can do about preventing the sudden death as well as heart disease. That's on October 1st from 11 o'clock onwards. And also we're going to give this to all the medical students and postgraduates from India too. So if your colleges want to inform the medical students and the postgraduate students, please let them know about the next webinar also, so that we want to have them educated. Number two, we're doing a governing body meeting in October, on October 7th and 8th in Atlanta. So we're going to have a fundraiser by our AAPI Women's Forum and the GAPI Foundation for suicide awareness in physicians. So please try to attend, if possible, the meeting in October 7th and 8th. If you go to gapi.org, you can find the information about the registration and booking the rooms. So thank you for a wonderful job. I think Ravi, if you can give the virtual plaque to the speakers, that'll be great. Thank you.
Thank you so much, Srini Gangasani, for being the CME chair for this year. We have another topic coming up in the next couple of weeks, non-CME presentation about COVID and the equity issues related to that by Pfizer. Please join that. And next, I want to give a virtual plaque to our esteemed speaker who done a great job. There's a lot of accolades here on the chat box as well as personal messages I'm getting about what an excellent speaker Dr. Prasad Padala is. I'm really proud that we found him as our speaker, and thank you, Srini Gokurkonda, for recommending Dr. Padala, and Dr. Padala, thank you for volunteering at a short notice. Again, the plaque says he is installed in our speakers as an esteemed member of our Speakers Bureau. And thank you very much, everyone. And we really appreciate. We have a lot of other activities planned, including Global Health Summit in Visakhapatnam. Dr. Padala, I think you're from Andhra Medical College, right? Please join our Global Health Summit in Visakhapatnam and January 6th to 9th, 8th in 2023. And we're looking forward to meeting you at the governing body as well. There is a fundraiser there. If you're getting some emails from AAPI, please open them, and you can contribute whatever little amount that will make a difference in somebody's lives. Thank you, and have a great day and be safe all. Thank you.
Thank you.
Thank you all. Take care. Bye-bye.